The purpose of this presentation is to describe the benefits of the electronic health record. The board and chief executive have both asked us to focus on the possible adoption of a computerized physician order entry system, or CPOE, and a barcode medication administration, or BCMA system. It is our hope to align the current research with our organization's vision statement and culture. We will spend time discussing issues surrounding both cost and quality. Our organization's vision statement goes as follows. We will support our core aspiration to deliver extraordinary care in all its dimensions with our vision, which is to provide the best clinical practice delivered in a consistent and integrated way and lowest appropriate cost to the population we serve. Today we will focus on how computerized physician order entry and barcode medication administration systems both address best clinical practice and fit within our vision of lowest appropriate cost. Computerized physician order entry systems are a way of reducing errors made when a physician using pen and paper writes a prescription. Data shows that nearly 50% of all preventable medication errors are made during this ordering process. Studies have found that 48% of those errors will be intercepted by the next phase of transcription, but more than half remain unchecked and unnoticed. Controlled studies of CPOE systems have shown up to a 40% reduction in a medication error rate. Studies show that by allowing the existing systems to remain, more than 25% of all preventable medication errors are made during the administration of the medication. With our current system, the first 3 phases of medication use are all followed by a system of checks and balances. The site of administration, however, does not. If an error is made at that time, no system is in place to recognize and catch that error. BCMA was administered by the Veterans Health Administration. In 1999, the VA reported a 24% decrease in adverse drug errors. Observational controlled studies have shown more than 50% decrease before and after implementation of barcode medication administration. While upfront cost and annual maintenance costs will be great, falling somewhere in the range of $1.5 to $2 million upfront and upwards of $150,000 to $500,000 annually, the cost savings potential is tremendous. Brigham and Women's Hospital, for example, in Boston recently reported a direct cost savings of $2.8 million for preventable adverse drug events, and estimates of $5 to $10 million additionally each year in indirect cost savings. Additional costs concerning time and training are a must. Without skilled nurses to assist on the floors and IT personnel to answer help desk calls, staff members are sure to become frustrated and develop ways of working around or simply working without the system. These issues of training and time cost begin to address other issues facing the implementation of such systems. During the planning phase of any implementation, specific departments and areas of the hospital should be assessed, piloted, and then evaluated for increased time and mortality. Some studies have found that the time-sensitive arenas, such as ICUs, can actually have care time impeded by extra time needed to use the computer. In addition to simply extra time, care should be taken to ensure that nurses, especially ICU nurses, are not taken away from patient bedsides in order to use computers. Care should also be given, and again perhaps pilot studies run, in situations that require very quick reaction times. Caregivers should be able to retrieve needed information quickly when that need arises. In summary, implementing systems such as computerized physician order entry and barcode medication administration will require great cost, both in money and in time and follow-through. Time in the form of training and support to every caregiver using the systems. The benefits of such a system, however, seem vast and if actualized, will outweigh any cost associated.